and expertise too.
Actually, I think there's a little bit of a misunderstanding. I don't really use the robot for breast surgery.
Okay.
But I have two hats I'm wearing. I'm here as the new director for minimally invasive and robotic surgery, but 50% of my practice prior to coming here was also breast cancer and breast diseases.
Okay.
So the other hat I'm wearing is to become the director of the breast center for Indiana Regional Medical Center as well.
All right.
So the robot, there are some people using the robot for breast, but it's a pretty far out there use.
Mm-hmm.
And so I'm here to talk about breast cancer and how we're going to rev up everything at Indiana. People think that they need to go out of town and even into Pittsburgh to get state-of-the-art breast care, and that's just not the case.
Well, let's get into the topic then. I know that when it comes to October, that's Breast Cancer Awareness Month, and we do all kinds of things in that area. But this is a good chance for us to talk about it again and talk about it a little bit sooner than that. Breast cancer is something that's just not going away as a topic of women's health, is it?
Right. No, there's more and more breast cancer in younger women all the time. And, we're now doing a lot of genetic research with breast cancer as well. And that's something I'm bringing to Indiana, is that I do genetic counseling and have been doing genetic counseling for about 8 or 9 years now. And so I do that right in my office. There's no need to go somewhere else. I do the genetic testing in the office. We're getting set up to have, we use a lot of social media. We're going to be getting set up to have telecommunication through the computer with a geneticist even, through the office. That's things I have in the works coming up here for patients with breast cancer.
All right, genetic counseling.
Mm-hmm.
Expand on that for me.
Well, the main cancer gene for breast cancer is the BRCA1 and BRCA2. We call them the BRCA genes. And any woman under the age of 50 is at risk for carrying that gene, even if there's no family history of that. That's something that people don't realize. Now, I also have to stress that more than 80% of breast cancers carry no genetic link whatsoever. They're what we call spontaneous mutations that occur, and there's no family history at all. Even without a family history, a woman under the age of 40 has about a 20 to 25% chance of carrying the BRCA gene or having a spontaneous mutation with it. And some of the things they don't realize, it's not just linked to breast cancer. It's if you have a family history of ovarian cancer. People don't realize malignant melanoma, the bad skin cancer, actually can be linked to the breast cancer gene as well. Young men with prostate cancer. So if you have a family history of a man under the age of 50 with prostate cancer, he should be tested, and probably the rest of the family tested for the BRCA gene. Mm-hmm. Pancreatic cancer, if there's a history of pancreatic cancer, that also has a mild link to the breast cancer gene as well. So it's a very large area. I could spend the entire time just talking about genetics.
Yeah, so. I bet. Make a pretty fascinating topic as well. But let's talk about a couple of things. Number one, you mentioned that the incidence of breast cancer are on the rise. Is that a product of people actually taking advantage of better diagnostics, and therefore learning about it more and earlier? Or is it a product of an actual increase in the cancers themselves?
I'm not an epidemiologist, and that's one of the biggest questions out there. But according to the epidemiologists, it is true increased incidence, not just increased testing. We do have much better testing techniques now, with the 3D mammography that's out, breast MRIs and things like that. We are picking a lot more breast cancers up at a lot earlier stages. And that also leads to better survival with breast cancer as well. Mm-hmm. But there are some very early breast cancers that there's controversy over, do we need to diagnose them even that early? Will they actually turn into anything? And that's one of the hottest controversial topics across the country. When I go to breast cancer meetings, that's debated. Are we overdiagnosing at this time? And that's something, but we don't know the answer to that right now.
Mm-hmm. And so let's turn to the treatment aspect of it. You mentioned that IRMC is sort of up in the game here. And really stepping forward again. We've seen these steps, and they've been big steps for Indiana Regional Medical Center in the last 10 or 15 years, but there's even more and better things coming.
Yeah, when I was being recruited mostly for the robotics, and then when I was talking to them, the bonus was that 50% of my practice was breast cancer. And I said, I don't just do robotics and minimally invasive. I do a lot of breast cancer. My wife is a breast radiologist, and prior to coming here, she and I have been doing breast cancer work together for 25 years, ever since residency. And so I wanted to see what was going on with breasts. And I was actually very pleasantly surprised with the breasts, too, as far as the facilities are concerned, just like I was with robotics. The Women's Imaging Center at IRMC is absolutely beautiful. You know, you walk in there, it's a very warm, welcoming place. It's not sterile hallways where you get stuck in some exam room somewhere or anything like that. And that's a big thing. You know, this is a very traumatic time, and it's a very beautiful area. It's a very relaxing area. You know, not that that takes all the stress off, but it helps. And IRMC has 3D mammography, and they do the breast biopsies here. They have a nurse navigator that will help, believe two nurse navigators that help patients through their course. You know, when they have the biopsy, they meet with the radiologist afterward. They go over the results. It's devastating. Well, they have a nurse navigator to help them through their course and get them directed to the right people for care and everything. And those are all big components of what we call a certified breast center. And that's what, talking with the administration, they were very eager to become a nationally certified breast center, and that's one of the things I'm working on as well.
Wonderful, wonderful. Used to be, you heard breast cancer, and there was perception breast cancer equals death sentence. It's not the case, is it?
Not the case at all anymore. And, you know, nobody wants to hear chemotherapy, but our advances in chemotherapy and hormonal therapy for breast cancer have really made a huge difference in the survival with breast cancer. People who used to have stage 3, which would be multiple lymph nodes involved, pretty much that was, you know, a done deal at that point, and it was a very devastating diagnosis. Now we have very long-term survivals because of our advances in the breast care. We also do more minimally invasive surgery for breast cancer as well. We know that the long-term survival for breast cancer after a lumpectomy is equivalent to a mastectomy in the vast majority of cases. So the old adage of, you know, I have breast cancer, I just want my breast off, is no longer really relevant because the vast majority of women can have a lumpectomy and have exactly the same 25, 30-year survival as if they had a mastectomy. But our improvement in long-term survival has been incredible over the last 10 years.
Let's talk a little bit more about mastectomy versus lumpectomy. Is it just a matter of the size of the lump that is considered, or are there other factors? I would assume that there are.
There are other factors, and that we do more extensive testing nowadays. You know, and like the genetic testing is one thing I talked about. You know, if you do carry the breast cancer gene, then you have a much higher risk of getting future breast cancers, including in the opposite breast. So the standard treatment for somebody who does carry the gene is mastectomy. However, for the most common breast cancer called invasive ductal breast cancer, if it's limited less than 5 centimeters in size, you can have a lumpectomy and have the same 30-year survival as a mastectomy. Now, you also have to realize that it's a cosmetic surgery. And the one thing I do is what's called oncoplastic technique when I do a lumpectomy. When you do a lumpectomy, you know, the true name is partial mastectomy. Okay. You know, the lumpectomy is the colloquial term for it. But it's a partial mastectomy. We take more than just the lump out. That can leave a cosmetic deformity to the breast. And there's a new term out there called oncoplastic surgery, where we do plastic surgery of the breast at the same time as the cancer surgery. It's funny, I laugh because when I was trained, it was called the proper way of doing it. You know,
now it's considered radical.
Now it's considered oncoplastic surgery. I was trained in a very large referral center for breast cancer, and we worked with the plastic surgeons, and I was taught by plastic surgeons how to do the oncoplastic technique. It's kind of been a lost art over the years, and so when I teach this, occasionally we have residents and things like that. When I teach this, I teach them the proper way of you mobilize or shift the other breast tissue to fill in the area so you don't have a big divot. You don't have a cosmetic deformity. If the tumor's too large, though, and you have a very small breast, you've lost the, you know, cosmetic advantage of a lumpectomy.
You mentioned a few moments ago going to conferences, which in the medical profession are very, very common. When you go to ones that deal specifically with breast issues, are there game-changing moments? Have there been a bunch of those in the last 5 or 10 years where all of a sudden the treatment options or the various results go in a whole different direction than maybe they had been headed?
Well, the biggest treatment option from a surgical standpoint that has changed is the evaluation of the lymph nodes. Okay. We used to do an entire lymph node dissection. You know, if you had breast cancer, even with a small breast cancer, you have up to a 10% or more chance of the lymph nodes being involved. So we used to go underneath the arm and clean out all the lymph nodes. That puts you at a significant risk for long-term swelling of the arm, 10 to 15% chance of chronic lymphedema of the arm, which is a devastating diagnosis when it happens. And also pain, because there's a sensory nerve that goes through there, is usually sacrificed. And you get phantom pain down the arm as well. With the sentinel lymph node biopsy, we can now detect where that first draining lymph node is. And the spread of breast cancer to the lymph nodes is not helter-skelter or blast effect. It's a very organized ductal drainage. So now we can find that first lymph node along that duct that drains to under the arm and go in and make a small incision and remove just a couple of the lymph nodes. And if those are negative, it's 95% accurate that the rest of the lymph nodes are negative. And we don't really have to take out any more of the nodes. And you avoid that risk of swelling of the arm and the pain in the arm and all that. From a surgical standpoint, that and the fact that the data for lumpectomy showing the 25, 30-year survival is identical to mastectomy have been the big game changers from a surgical standpoint.
You know, just listening to you talk, it seems like every breast cancer case that presents itself to you and to others within the field is a chance to learn as much as it is a medical outcome. They do tend to educate you every time you look at a breast cancer, don't they?
Yeah, because every breast cancer is different. You know, we look at each cancer individually now. We don't, and that's been a big game changer too. These have been more gradual because the research has to come out, but we now look at, we stage breast cancers. Even if you have a small breast cancer, we look at the pathologic grade. We look at 3 different things under the microscope and figure out how atypical the cell actually looks to see if it's a low aggressive growing tumor or a highly aggressively growing tumor. We look at the receptors on the cancer cells for estrogen and progesterone to see if it will respond to hormonal therapy. If you don't have those receptors, then that tends to be a more aggressive tumor as well. We look at the actual receptors called a HER2/neu receptor. That is, you know, another one. If it's on there, it tends to be more aggressive. But we have great treatment for that if it's on there, a medication called Herceptin. We also look at the proliferation index called a Ki-67 that tells us how rapidly the cells are growing. Sometimes even beyond that, with a small tumor, we'll send out genetics on the tumor itself. And there's things out there called an Oncotype DX and a mammoprint that will estimate a woman's risk of future development of cancer spreading elsewhere in their body, which will make a difference even in a small tumor as to what kind of surgery or chemotherapy or hormonal therapy is necessary later down the road.
Wow. So, there's another couple of hours worth of conversation here in Indiana in the morning.
We could have a whole series on it.
Don't say it too loudly. I'll make you do it. Have the mammogram, obviously.
Right.
Don't ignore the results.
Absolutely.
And to see Dr. Clark, 724-463-1414. That's 1414-463-1414. Of course, the Central Call Center, 888-452-IRMC for any appointment, not just the topic that we've been covering today. And you can also, of course, go to irmcdocs.org. All right, so we'll have you back in another couple of days. We'll find out something more. No, it's good to have you with us, though, again today. We appreciate you coming.
Thanks for having me.
He's Dr. Dan Clark at the Indiana Regional Medical Center, the IRMC Physician Group. It is 8:59. Fox News is next. It's Indiana in the Morning on WCCS.